Welcome, everybody. Today, we are diving deep into a system that demands our utmost vigilance, the neonatal hematologic system. This system is adapted for fetal life, where survival depends on capturing every possible molecule of oxygen in a hypoxic intrauterine environment. However, that very same adaptation leaves the newborn profoundly vulnerable to extrauterine existence. Our core teaching pearl for today is this. The neonatal hematologic system is a mechanism optimized for fetal oxygen transport, not for postnatal stability. Early recognition of its transitional limitations and careful clinical monitoring can quite literally save lives. To effectively manage these vulnerable patients, we must first establish our baseline. The neonatal hematologic profile is radically different from that of an older child or an adult. At birth, we see significantly higher hemoglobin and hematocrit levels, driven predominantly by fetal hemoglobin, or HbF. Yet, look at the trade-off. Neonatal RBCs have a drastically shortened lifespan of just 60 to 90 days compared to the standard 120 days. This accelerated turnover causes a massive surge in bilirubin production at a time when erythropoiesis is declining sharply post-birth. Furthermore, their reserves are remarkably restricted. Preterm infants face variable and limited iron stores, while all neonates present with reduced coagulation factors, immature platelet function, and a highly limited bone marrow reserve. The clinical reality? A significantly elevated risk for bleeding, severe hyperbilirubinemia, and, in preterms, catastrophic events like intraventricular hemorrhage. We cannot apply standard pediatric norms here. We must view every lab value through this distinct neonatal lens. Let's dissect this transition further by looking at what I call the oxygen trade-off. Inside the womb, the fetus adapts to hypoxia by maintaining a remarkably high hemoglobin, typically 14 to 22 g/dl, and a hematocrit between 45 and 65%. HbF makes up 70 to 90% of this total pool because its high oxygen affinity is essential to pull oxygen across the placenta. But once the cord is clamped, these brilliant adaptations transition into profound postnatal vulnerabilities. First, we face the viscosity risk. An excessively high hematocrit can easily trigger polycythemia and hyperviscosity syndrome, reducing tissue perfusion and risking organ infarction or stroke. Second, we have the hypoxia risk. Because HbF holds onto oxygen so tightly, it releases it less efficiently to the tissues. During an acute illness, this shifts the tissue oxygen delivery curve dangerously to the left, worsening cellular hypoxia. Finally, as tissue oxygenation improves after birth, erythropoietin drops sharply, leading to the predictable physiologic anemia of infancy, which hits its nadir at 10 to 12 weeks in term infants, but occurs much earlier and drops far deeper in our preterm population. This brings us directly to a phenomenon we manage every single day in the NICU, what I term the jaundice engine. Hyperbilirubinemia is not an arbitrary event. It is a mechanical consequence of neonatal physiology. Think of it as a funnel. Feeding into this funnel, we have two massive physiological streams, a shortened RBC lifespan of 60 to 90 days, and a massive circulating RBC mass. This creates a huge volume of cells breaking down simultaneously. Now, add a pathology modifier, like ABO or Rh incompatibility or G6PD deficiency, and you slam a heavy multiplier on hemolysis. All of this debris hits a critical bottleneck, hepatic conjugation immaturity. The newborn liver simply lacks the enzymatic maturity to conjugate and clear this overwhelming volume of bilirubin efficiently. When the engine overflows, we are left with a strong predisposition to physiologic jaundice at best and severe hyperbilirubinemia, profound anemia, or catastrophic kernicterus at worst. Anticipating this structural bottleneck is key to timing our phototherapy and exchange transfusions. Let's shift our focus to hemostasis. Neonatal hemostasis is a fascinating paradox. On one side of the scale, neonates have reduced procoagulants and platelets, specifically lower levels of vitamin K-dependent factors 2, 7, 9, and 10, reduced contact factors, and functionally immature, less reactive platelets. This naturally prolongs their baseline PT and APTT. To compensate, nature balances the other side of the scale by reducing their natural anticoagulants, leaving them with lower levels of protein C, protein S, and antithrombin 3. This creates a system that is perfectly balanced under ideal conditions, yet highly immature and fragile. The true danger arises when systemic stressors hit, such as sepsis, asphyxia, severe illness, or even the placement of central lines. This heavy weight violently tips the scale. Because they have zero margin for error, the neonate can rapidly swing into either severe bleeding, such as vitamin K deficiency bleeding and DEED-C, or sudden, severe thrombosis. When things go wrong in the NICU, they go wrong quickly because neonates lack systemic backup. They face what I call vulnerability multipliers. First, consider the small fuel tank, their limited bone marrow reserve. Unlike older children, a neonate's marrow cannot rapidly ramp up the production of neutrophils, platelets, or RBCs during a crisis. When a massive stressor like early-onset sepsis strikes, it quickly drains the tank dry. This explains why we see sudden, profound neutropenia, thrombocytopenia, and severe anemia manifest within hours of an infection. Second, they carry the broken shield, an intense oxidative vulnerability. Neonatal RBCs have immature antioxidant defense systems that lack sufficient glutathione, superoxide dismutase, and catalase. This leaves their cell membranes highly susceptible to oxidative injury and spontaneous hemolysis, a vulnerability that is severely exacerbated by illnesses or underlying conditions like G6PD deficiency. If term infants are fragile, preterm infants pay what we must call the preterm penalty. By delivering early, these babies completely miss the crucial third trimester transfer phase, compounding their clinical fragility in a cascading step-down effect. By missing this window, their iron stores are critically depleted, drastically increasing the depth and speed of the anemia of prematurity. Their baseline vitamin K stores are dangerously low, heavily magnifying spontaneous bleeding risks. Structurally, their cerebral vasculature is incredibly fragile. The immature blood vessels in the germinal matrix create a distinct, ever-present risk for intraventricular hemorrhage. When you combine these factors with a systemic trigger like NEC or placental insufficiency, you drive severe thrombocytopenia, multiplying the bleeding risk exponentially. The resulting burden we face in the pod is a profoundly higher incidence of IVH, severe anemia, and a heavy, high-risk dependence on transfusions. To synthesize everything we've discussed, let's look at how these physiological roots map directly to our daily clinical pathologies. Every major hematologic complication we treat does not occur in a vacuum. It maps back to a structural developmental limitation. Our first root, a short RBC lifespan combined with a high RBC mass, is the direct fuel for jaundice, whether physiologic, hemolytic, or breastfeeding associated. It also directly feeds into anemia via accelerated breakdown. Our second root, immature coagulation and platelets, maps directly to bleeding disorders, including VKDB, DC, and thrombocytopenia. Our third root, falling EPO combined with limited iron and marrow reserves, is the primary driver behind the anemia of prematurity and the infant's inability to compensate for blood loss or active hemolysis. And finally, our fourth root, a high baseline hematocrit mixed with reduced anticoagulants, explains the high structural risk for thrombosis, particularly when we introduce triggers like umbilical catheters or central lines. As clinicians, seeing these lines of connection allows us to treat the underlying physiological vulnerability rather than just chasing the laboratory numbers. We conclude with our actionable clinical directives. How do we translate this physiology into excellent bedside care? First, anticipate instability. We must respect the precarious nature of developmental hemostasis. Never wait for a clinical crash. Anticipate that even minor systemic disturbances, a mild sepsis workup, a brief spell of asphyxia, can violently shift this fragile system toward massive hemorrhage or extensive thrombosis. Second, maintain meticulous monitoring. Ensure close, continuous, trend-based monitoring of hemoglobin, hematocrit, platelets, bilirubin, and coagulation profiles. This is non-negotiable in sick or preterm infants whose bone marrow reserves can deplete catastrophically fast. Third, implement active preventive strategies. We must actively bolster what these infants missed from fetal life. Prioritize delayed cord clamping whenever stable, to optimize baseline iron stores. Ensure optimal early postnatal nutrition to support erythropoiesis, and practice judicious, evidence-based transfusion thresholds. Remember, every transfusion carries its own oxidative and immunological stress to an already vulnerable system. By understanding the fragile balance of neonatal hematology, we move from reactive crisis management to proactive, protective care. Thank you.